I don't need a microphone. All right. Good evening. For those of you that don't know me, I'm Kristen Van Berkel, the fitness director here at Riverbend. Thank you all for coming. Whatever the reason that brought you here to listen to this talk, I can assure you this is the gentleman that you want to hear talk about it. So I will hand the floor and we will all welcome my dear friend, Dr. Ian Ball.
Good evening, everybody. Thanks for being here. This is the third time that I've had the opportunity to speak to people. Can you hear me okay in the back? No? So he's kidding. All right. Can others hear me okay in the back?
Yeah, you speak out, that would be helpful.
Okay, I'll try the mic then. I thought I'd be okay, but maybe not.
Only so that's not to talk.
That's cool. It's
Can you? Is that better?
No.
I don't think it is.
Can you hear me in the back?
Can you hear me?
Yeah.
Now it's working. Better? Okay. I don't usually need a microphone, but that's okay. So this is my third opportunity to speak to this group, and I'm gonna guess that there's probably some people who are here for the first one and or the second one who were not. So what my plan was to give you a very brief overview of how I got involved in medical assistance in dying and the history of it at London Health Sciences Centre since 2015, 2016. But that'll be fairly brief, partly because that's sort of old news, and it's also some of you have heard about it before. So the main focus of what I wanted to share was things that have changed, things that are anticipated to change in the coming 8 months or so, 10 months, and then current controversies, current challenges, but most importantly of all, I'd just like to allow at least 20 minutes, maybe 30. To open up the floor for questions and discussion. So hopefully that suits everybody here. Okay, thanks. So yeah, my name's Ian. I'm an ICU physician at London Health Sciences Centre at Victoria Hospital. And I trained here, started in medicine in London in 1998, so it's been a while. And back in about 2015, Canada was preparing for this new legislation that allowed medical assistance in dying for the first time. And I was at a meeting because I was very heavily involved in organ donation in London and in the province. I was meeting with our hospital ethicist about how would we handle the challenge of patients who wanted MAiD and then wanted to donate their organs after. And at the end of the meeting, everyone left, and I stayed and I said to him, which doctors are doing MAiD? Because the program was gonna start in a few months, the legislation was gonna allow it. And he said, well, actually, it's a pretty small list. And I said, how do you choose people? And he said, well, people mostly volunteer. And without giving it a lot of thought, I said, well, you can add my name to the list. And didn't think I'd really ever hear about it again. And then I distinctly remember, so this was spring of 2016, getting an email and sitting in my house, and I read it over 2 or 3 times because it seemed pretty surreal. And it was him reaching out to say, would you be willing to do our first case, which ended up being one of the first 2 cases in the country, not including Quebec, because as many of you know, Quebec got a head start on the rest of the country in this. And it was pretty nerve-wracking. And particularly, I was nervous for the consequences doing this might have on my practice at work. Would my colleagues think of me differently? In the intensive care unit, we have to withdraw life support on a lot of patients, and that's always been a challenging part, sometimes rewarding part as well, to help families through this difficult time. But I was concerned that if I had this reputation for doing MAiD, would that color this other important part of my job? To cut to the chase, it hasn't. I'll finish off. And the other thing I was worried about was the implications for my family. You know, at the time, we were worried that MAiD might be received much the way abortion was received in the 80s. You know, they tried to kill doctors, they took shots at them. One of the abortion providers in London used to drive a bulletproof car, wear a bulletproof vest in public. He literally wore a disguise with his hat down low and sunglasses. You know, people made death threats to his children. And so I was concerned that that might happen. So I tried really hard to keep it secret for about a year. And then what started happening was it was very difficult to keep secret, and more people started learning about it. And as more people learned about it, more people, both friends and strangers, would just approach me randomly and say, just want to let you know, like, completely supportive of what you're doing, you know, and many messages like that. And I would say probably had about 99 reassuring and supportive messages for every critical comment, and very few actually, even so 2016, right? So 7.5 years, I can count on two hands how many really negative comments I've received in that many. So not even once a year on average. There were some nasty things written in the press, the Wall Street Journal, one of the big newspapers in Ottawa, you know, but for the most part, people have been very supportive. This was never really something that I was a strong advocate for. It's just that there are just some people where they're suffering and they're dying and they're uncomfortable and they've lost their dignity and they're just waiting for something, you know, for a horrible death. And, you know, we've all been sick before, and some of you have probably been a lot sicker than I have, but, you know, no matter how sick I am, I always know that if I can just get through the next few days, I'll start feeling better and everything will be fine again in a week or 2 weeks or whatever it is. But, you know, the patients that I provide MAiD to, they feel horrible and they're suffering. Maybe they're short of breath, which I think is worse than pain, probably. But some of them have shortness of breath and pain. And every day it's going to get worse and worse. It's never going to get better, and it's not even going to stay the same. And, you know, all they have to look forward to is that day when they die. And I can't, it's still hard for me 7 years later to imagine what that must feel like never getting better. It's only going to get worse. And the only thing you have to look forward to. And one of the messages that we've received, because I talked to a lot of patients and a lot of families, is one of the most rewarding parts of the MAiD program for me is we'll often meet with families and patients where they've been given an end-of-life diagnosis. You have metastatic lung cancer, you have a few months to live, or maybe a year. And so they call us and I go see them, and I have to do an assessment to decide whether or not I feel that they meet the legislative requirements to receive medical assistance in dying. And essentially, and I'll get into this in a second about how things have changed, but in the early days, you had to be dying. So your death needed to be what's called foreseeably imminent, and you had to have capacity, meaning you had to understand, be able to cognitively understand and appreciate the consequences of asking for MAiD and what this meant for your health and your decision making. So often I would see these patients and they're just like you and I. You can talk to them, so clearly they understand what they're asking for. And if they have metastatic cancer, it's pretty straightforward that yes, you qualify. And a lot of these patients would say to me, I don't want it now. I don't need it now. I'm fine. I'm living at home with my family and life is still good. My symptoms are well controlled. I just want to know, it's almost like an insurance policy. I want to know that when things get bad, because they know they will, right? I mean, this is an end-of-life diagnosis. When things get bad, if I start to feel too short of breath, or my pain gets too bad, or I start bleeding too often, or a big one that I hear a lot is I can't stay in my house anymore because my family and I can't care for me. I need to be institutionalized. If and when that happens, I want to call you. And we say, yeah, absolutely. Deal. And I tell people, like, we're very transparent, like probably 50% of the people I have that conversation with, I hear from again. 50% of them presumably die in their sleep, and we never hear from. But 100% of the time, families and the patients tell me what a tremendous improvement in their emotional well-being. I don't have to just expect for this to get worse and worse and worse and worse until I die. And maybe I die by myself. Maybe I'm choking on my own blood at 2 a.m. without anyone around, right? No, like when the symptoms get too bad, I pick up the phone, I make a phone call, I get my family together, you know, we burn candles or play music or wear our pajamas or wear my best suit, and put my dog on the bed or whatever it is they want, and it will be very humane and compassionate. Like almost, I've lost track over the years about how many times, how many procedures I've done, but virtually every single one of them, the families come up after and they're very grateful, and they want to give you hugs, and they tell you just how incredibly humane and peaceful the whole process was. So I could go on about kind of early days, but really that was the introduction I wanted to give you about that's 2016 until about a year or two ago. And then I'll maybe stop, see if there's any questions or comments, because it's probably better to do it that way. And then maybe I can move on and talk about recent changes in the last year or two. We can stop, have some discussion and questions, and then I'll tell you about some of the new things coming down the pipes in the next year. So any comments or questions about what I just shared so far? Kristen, maybe you can help.
How can you initiate these meetings with the doctors to do this?
So how could a person start this?
Yeah.
Okay, so I'll just repeat the question for the people online. So the question is, how does a member of the public who is interested in MAiD, MAiD provider? I'm paraphrasing a little bit. So in London, there's two different ways. So there's a community MAiD provider or a MAiD navigator. To be honest, I don't know as much about that, but you can probably just look up on the internet for like London and MAiD, and you'll probably find it. At LHSC, it's on our webpage. So that's probably the easiest way. If you are not comfortable with the internet, you can just pick up the phone and call London Health Sciences Centre and ask to be connected with a MAiD navigator. So that's a full-time person that we've hired who helps to organize all the logistics of MAiD and put patients with people who do assessments and provisions. I don't know, to be honest, outside of the London area, probably most people here are fairly local, but I don't know how you would do it if you're in, Owen Sound or something like that. Presumably a good point of contact would be your family doctor. I will tell you that doctors have an obligation to not abstain patients and a MAiD provider. So even if your doctor doesn't believe in it or doesn't want to provide it, they are not allowed to get in your way. So they have to help you, or their college will punish them. Much like abortions, right? A doctor is not obliged to provide an abortion, but they have to make a referral to, an honest referral that will put you in contact with someone who will. Other questions?
Not during COVID, but say now, if someone got COVID, they were elderly and it didn't look good at all for them. But they're still a sound mind. Is COVID under the criteria of being able to end your life?
So the question was, what if you had COVID and you were of sound mind or capable of making decisions? So
But you were getting to the point where you're on life support.
yeah, so on life support, so that's definitely in my wheelhouse. And we do occasionally have families that ask about MAiD for patients on life support. You don't need MAiD if you're on life support, because the definition of that is without the life support you would die. So what we do in that case is it's just so much more simple for everyone if we withdraw the life support and give people medications to keep them comfortable. And that's very, very MAiD. I'm, as an ICU doctor, been doing that since I started working in the intensive care unit, and we're always very clear with patients and their families that that's not killing a patient. That's removing the technology, the machines that are keeping them alive, and at the same time administering medications to keep them comfortable. While I'm on that, this comes up all the time. People who work in the ICU who've been doing this for years will say to me, "Oh, MAiD, that's just similar to what we do in the ICU." I can assure you, it's extremely different. It may seem to the person on the outside looking in, but I mean, there's a very big difference between removing a machine that's keeping someone alive and administering medications to someone who may have woken up that morning in their house, had breakfast, gotten in their car, driven to the hospital to see you, and was telling jokes, walked into the room, and then you're administering medications. They're very different.
What about someone with end-stage pulmonary fibrosis. A criteria? for
Sure. So the question was, what about someone with end-stage pulmonary fibrosis? So I actually saw a patient today who had end-stage lung disease. And yes, so I mean, those types of patients, their death is foreseeably imminent. So yes, and to add to that, one of the parts of the legislation is that you can refuse any kind of treatment you want. So if you refuse treatment, then is your death foreseeably imminent. So there are people who, so I had a patient many years ago who was dependent on dialysis. He had kidney failure and he got dialysis Monday, Wednesday, Friday for his whole life. Without dialysis, he would die. And he'd had dialysis for 12 years or so. And then one day, I guess he just was fed up. He wasn't happy with his quality of life. And he called us and said, you know, I want your help. I don't want to live this way anymore. Well, like if he could walk into this room, he could go play golf on your golf course and eat lunch and dinner, but he qualified because if he refuses dialysis, which is a medical intervention, his death, he would be dead in a few days. His death is clearly foreseeably imminent. So we went ahead with that case. Yes, go ahead.
If you live on your own and you don't have family around, is it something you can do legal too with a lawyer that would be the wishes?
So the question was, if you live alone and don't have family around, the second part?
And this no decision that can be made for you because nobody's there, but that you do this in advance if you get to that point.
Right. Because you asked the question, I think I'll just jump in because that's the next part of the talk. So what you're talking about, I think, would be something we call an advance directive, where you can say, if I'm not able to speak for myself, this is what I want. And you can talk to your family about that. You can talk to a lawyer about that. But that's what you're asking, right? So in the early days, in 2016, 17, 18, you could not do that. So it was the only procedure that I'm aware of in all of medicine and surgery where you could not provide an advance directive. And so the legal requirement was on the day of the procedure, immediately before the procedure, I had to legally ask you, are you sure you still want to do this? And if you were not capable, you weren't cognitively able to understand what was going on, then I legally could not proceed with the procedure. And that threw up a whole bunch of problems. So a few examples, because this is where I was going in the second part anyway. But I had a bunch of patients who had metastatic cancer in their cancer was in their bones. Super, super painful, cancer bones in their back, broken ribs, so that every time they rolled over in bed, they had terrible pain because they had broken ribs. Every time they coughed, sneezed, laughed, rolled over, they had used their pain medications for 2 days before the procedure because those pain medications can cloud their mind. And I warned them, because I had to, look, if you're confused from your pain medications, I can't do this procedure. And that's really inhumane and unethical, right? So you're forcing them to suffer even more for the last 2 days in order to be eligible. So that was a problem, and the government was aware that that was a problem. So that's example one. Example two, and there was a famous case in Halifax that was all over the press, probably a bit before COVID, maybe 2018, 2019, where there was a lady who'd been diagnosed with some form of progressive dementia. And so she didn't want to live with this dementia when she could, and a lot of people probably in this room, I'm guessing, I certainly feel this way. Like, if I don't know who I am, I don't recognize my family members and so on. Like, for a lot of people, that they don't want to live that way. And that's how this woman felt. The problem was, by the time you're in a state that isn't acceptable to you, you're no longer eligible for MAiD. So you had two choices. You could either get worse and decline MAiD earlier than you really wanted while you were still capable. Neither one of those is good, right? And so she argued that this law discriminates against people like me. And that case made a lot of waves. And so that changed the rules. So as I get older, the time gets a bit warped, but I can't remember, it was about 2 years ago-ish, maybe a year and a half, that you can now provide an advance directive, so to speak, for MAiD. But it's still a lot it's very specific compared to most forms of advance directives. So you have to meet with your MAiD doctor. You have to say to them, if I lose capacity to make this decision, I still want you to go ahead with MAiD. You have to meet with the same doctor who's gonna do the procedure. And so like at the hospital, I mean, we're not all there 365 days a year. So if you meet with me, but then you need this procedure 3 months from now, and I happen to be, out of the country, no other doctor can do it if you're confused, other than that same one. And then the other part of the rule is you can't be like pulling your arm away when the doctor's trying to give you medications. So to be honest, I've not done a case like that. But that is a new rule that you can meet with the doctor if I get to a place where I can no longer consent because I'm no longer capable. I would like to proceed, and that is now legal. Please.
Say you don't have an advanced directive, you don't have children, you don't have friends, nobody out there for you, and you did do it with a lawyer, but you are dying, and you need morphine and Dilaudid and whatever drugs they give you now for pain control. Are you saying you have to wait? They have to wait on those medicines to give you before you can go ahead and say, yes, I want this done today at 2? Like, how does that work?
Yeah. So no. So it's not really an advance directive. So to the first part of your question, you just have to meet with the doctor who's going to do the provision when you're of sound mind and say, if I get confused or I no longer have capacity, I still want you to proceed. And that's all. So you don't need a lawyer, you don't need your family, you don't need a document, you just need to meet with that doctor, but it has to be the same doctor who's going to do the provision. And then back to the morphine and Dilaudid, so narcotics or opiates that we call them. It's okay to be on them, so I didn't want to confuse anybody before. It's just that if you take too much of that, they can confuse people. And so it doesn't mean you, and the other thing is, so supposing I go in tomorrow to see somebody and they've got a bunch of, they've got cancer in their back and in their ribs, and so they've had to have extra narcotic that day, and I talk to them and I say, well, they're too confused. I can come back tomorrow and maybe they'll be better tomorrow. Maybe they're just a bit more used to the medications, or maybe we gave them a bit too much yesterday and we just turn it down a little bit, and they could still consent the next day.
So you won't do it if they're under those drugs, you definitely.
So in the early days, yeah, I know. In the early days, if you had to be clear, you had to be lucid on the day of the procedure. Now, you have to be lucid at some point, but you can be lucid, give consent today for the procedure 3 weeks from now. You don't need to be lucid 3 weeks from now. Please.
I was under the impression that anybody who seeks MAiD needs to be examined by 2 doctors. Is that so?
So I'll just repeat the question for the people online. So do you need to be examined by 2 physicians? 2 physicians, or 2 either nurse practitioners or physicians. So yes.
Okay. The reason I put it that way is because of the fact that if in fact you have an advance directive and you have been chosen as the one to perform the procedure, which are not available, can the other second person, if it's preset that way or recorded in the patient's records?
Yeah. So the question is, so if 2 doctors have to sign off that you're eligible, and 1 doctor is the specific doctor who's doing the provision, and they're not available weeks later, days later when you want the procedure, could the other doctor do it? No, it has to be the same one. Now, could you have multiple doctors be the one and sign? I think so. I'm not perfectly sure, but I think so.
Yeah,
I've never encountered that situation.
That was where I was headed.
Yes. So,
if it's predetermined or
yes.
the advance notice is given to both doctors, whether it's at the same time or not, then in the absence of one, the other can?
I'm pretty sure that that's correct. Yes, sir.
Okay, thank you.
This is a little different. Say I was in a car accident and I was brain dead. I would not want to live in that condition. So would I, at this stage of my life, have some documentation that I don't want to live? Or can my family step in and say, no, you're not going to take her off life support?
Okay. So These questions are all long. I have to work to remember them. So the question was, again, tell me if I have got this right. I'm gonna paraphrase, but if I was in a car crash and I was brain dead, what would happen? How's that? So doesn't need to have any. I just want to reassure people, before MAiD, we still had pretty good mechanisms to take care of all these difficult situations. So this happens all the time where I work. If you've had some horrible accident, it could be a car crash, it could just be some other medical catastrophe, and you're brain dead. So that word brain dead has a very, very specific criteria in medicine. If you're brain dead, you're dead. You're medically dead, you're legally dead. And as soon as the doctors finish assessing you and declare that you're brain dead, then there's no decision to be made. We'll go to your family and say, we're really sorry, she's dead. You could still have a pulse, you could still have a blood pressure, you could still even have some very fine, uncoordinated movements of your arms and legs, but you're legally dead, and then we turn off the life support because it's inhumane to continue life support on a body who is legally dead. Now, the next question to that, before we go to you, Baxter, was what if, so you're not brain dead, so what if you just have a very, very bad brain injury, for example, and you're on life support? So you're not dead, but you wouldn't want to live that way because, you're in people use the term vegetable, we don't use that in medicine, but I think most people understand what that means. Then, so legally, I, as a physician, have to have your consent to do anything, to give you any kind of medical treatment. And I can't talk to you because your brain isn't able to communicate with me. So then what we do is we approach substitute decision makers, which are usually family, and that legally there's a hierarchy. So spouse, if you're married, children, parents, aunts, uncles, it goes on and on. There's an entire hierarchy, but we would approach them and say, and the question to them isn't please decide what she would want, but more you've known her for a long time. What do you think she would say in this situation? And if they knew you, they would say, well, she told us that she would never want to live this way. You should turn off the machines, and we turn off the machines. So no MAiD is necessary.
3 out of 4 would say pull the plug, the other one would say no.
So I'll repeat that, but 3 out of 4 would say, remove the life support, and 1 wouldn't. And this happened in my career is that we say that, these extremely difficult times bring out the best in families, or they bring out the worst in families, and we see both.
What do you do?
Power of attorney?
So lots of people don't have power of attorney. And the other thing about a power of attorney, and I actually distinctly remember sharing this with this group years ago, was many of these documents that people go and get from their lawyers are not helpful at all. And our social worker brings me these documents, and I know what they're going to say, and they say things like, if in the opinion of, often it's my doctor, there is no reasonable hope of a meaningful recovery, then da 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 da. Well, I don't know what a reasonable hope means, and I don't know what a meaningful recovery means. And so this document is useless, right? Now your family may, but now we're back to square one. Now I'm talking to your family, which means the document's not very useful. So very, very rarely, like 1 or 2% of the time, I get documents that are very, very clear. If I don't know who I am, if I can't recognize my family, if I can't, go home and live independently, those types of things. But that's extremely rare. Most documents I've ever seen, having done this for 2 decades now, are those very vague, nebulous ones that don't help me. Yes, ma'am.
To Diane's point, if you have somebody designated as power of attorney, and the other siblings or whatever aren't, don't you go by the power of attorney person?
Yeah, so the question was, what if you but other people disagree with the power of attorney? Yeah, so that we listen to the power of attorney, and that's it, that's all. Yep. And we still try to help families so that, they don't hate each other forevermore. But ultimately, yes, we listen to the power of attorney. So all the way in the back, I think. Go ahead.
Is this something that you need to pre-arrange ahead of time, or are you like a specialist that you
Yeah, no, that's a fair question. I have pretty thick skin, it's hard to offend me. So the question was, do you have to arrange this ahead of time, or do you have a big wait list? So let me go off on a slight tangent to that question, and that is, there's no such thing as a MAiD specialist. And unfortunately, MAiD falls between all the cracks in medicine. Like, it doesn't belong to the family doctors, it doesn't belong to anesthesia, it doesn't belong to ICU physicians like me, it doesn't belong to palliative care, it falls through the cracks. And so no specialty has owned this. And so there aren't standards, there's no formal training. And so it's a real problem. And I don't know if that was intentional by the people that made all the rules or not, but it's a real problem. So to answer your question directly, in London at LHSC, because that's the program I know well, we can arrange this fairly quickly, meaning 2 days. Sometimes we could do it in 1 day, but I always advise, remember at the beginning of this evening, I said, families ask, well, can I call you 6 months from now, 4 months from now, if the wheels start to fall off? I always say, yes, just give us a call, but I always advise them, don't expect it. Like, you can call Tuesday morning and book a time for 2 o'clock the same day. Give us a couple of days, because it's not the patient's fault, but there's a lot that has to be organized on our end. We need to find the two doctors. We need to coordinate this with pharmacy. The other thing that we do at LHSC is I insist on a very trustworthy intravenous line. And if you put yourself in my shoes, the worst thing that could ever happen is we administer half a dose of the procedure, the medications, and then I lose my IV, right? Which isn't something a patient would think about, but many of the patients are dehydrated, their kidneys are failing, many of them have had chemotherapy and their veins are bad. And so I insist on a very particular type of line that I trust completely. And so that often will take us a day or two to put in place. There have been cases in London, not my cases, and not cases in the hospital where that happened. So, you've got family gathered around, it's a very solemn occasion, and mid-procedure, they lose the line, doctor panics, no one knows what to do, it's horrible, the patient's in very bad shape, they're sort of half dead, but not dead. They call 911, the paramedics say, well, what do you want us to do? Because they're not to resuscitate, they were there for MAiD. They show up in emerge, the emerge doc says, what do you want me to do? Because they can't finish the MAiD procedure, because that would be illegal, because they're, so it's, so we make sure that we have the proper IV, and if that takes an extra day or two, it does. And I've had many, many cases over the years where families have been quite upset because we couldn't get this done, today or tomorrow morning. And unfortunately, most of us do this kind of because we think it's the right thing to do, sort of aside from our regular job, and we do the best we can. There isn't a big waiting list, though, to answer that in a short one. Yes, and then, go ahead.
Is there a fee?
A fee? No, there's no fee. This is covered. On that note, though, I will tell you that on the forms, you have to have a valid health card. And I'm pretty sure the reason they've done that is to prevent travel tourism, so that you don't get people from other countries coming to Canada for MAiD, which does happen in Switzerland, for example, where there's a very expensive, I think it's $25,000 to $30,000 fee to have this done, but there's no cost if you have a health card. Here and then over there.
Okay, are you saying that you prefer a PIC line established? Is that what you're looking for?
Absolutely. So I didn't use.
Did you have to go to someplace that has a PIC line?
No.
Place?
Yeah. So a PIC line, I didn't use the term just because I figured most people. So a PIC line is a special IV that's quite long. It goes in generally in the front of your elbow, and it goes all the way up and sort of into the top of your heart. And I trust it. It's 99 point something % trustworthy. Much better than a traditional intravenous line. I'll use other lines if a patient already has a dialysis line or another very, very secure line. But if the patient is already an inpatient at LHSC, we can have it done, if you ask for it, today's Thursday, I could probably get it for you tomorrow. If you're an outpatient, having the procedure done, we'll bring you in and have it done the morning of. So I typically do these procedures mid-morning, and if you show up at 8, we'll get the PIC line at 8:30, and we'll be ready for the procedure at 10 o'clock type of thing. Go ahead.
Are you only doing this procedure in a hospital setting, or are you the option from home? So they could have, because they might be too weak to go for the PIC line placement.
Yep. So good question. I've forgotten to repeat a few of the questions. So question was, are you only doing the procedure in hospital, or are you providing it home? And if you're providing it home, maybe they're too weak to come into hospital to get a PIC line. So we do both. So we do, the LHSC doctors will go to people's homes. And if we can bring a patient in, many of these patients, the home patients, tend to plan a little bit further ahead because they're less sick if they're at home usually. And so often they have appointments in the hospital. So the first thing we'll do is try to coordinate it with an appointment in the hospital. And oh, you're coming in next Tuesday? Perfect, we'll book a PICC line insertion for you when you're here next Tuesday. For patients who are too sick to come to the hospital to have a PICC line, we will do other things. So I've gone to people's houses and started 2 lines, and I do warn them ahead of time, like there might be a, you know, getting a line that I trust. You know, we may not be able to do it on the day we've planned, which is a big deal. I understand that. I mean, if you've got it in your head that it's gonna be on Wednesday, and I show up and, you know, I'm pretty worried about the IVs, I'll tell you that's never actually happened to me, but I do warn people that it's a possibility. Most of the time, we're pretty good about being able to get people to the hospital to get a PICC line. So those are our approaches. Go ahead.
Could a home care nurse come in and establish an IV, pump them up a little bit with maybe 500 saline, open up that IV for you and give you good blood pressure for you, so they don't have to travel. How far is they don't have to travel?
For sure.
And sit around and
Yeah.
cold, ambulance,
Yeah.
whatever.
So the question is, could a home care nurse help do this? Yes, and we've done that. So lots of different options that we consider to try to make this as comfortable as possible for the patient. I think there was a question. Yes, ma'am.
I think I heard it, but I'm not sure. Are you able to be in any of the hospitals?
So another theme. So the question is, can you have this done at any hospital? So definitely not. So LHSE, University Hospital and Victoria Hospital, yes. Joe's, absolutely not. Parkwood, absolutely not, because Parkwood is run by St. Joe's.
Yeah, so how do they get?
It's a huge problem because those hospitals, so the follow-up question is, if you're too sick, how do you get to those? So those hospitals won't even allow us in to do an assessment. We're not allowed to go talk to patients. Even though I have privileges at St. Joe's, I work in the ICU at St. Joe's, but as a MAiD doctor, I'm not allowed to go talk to a patient. So that gets tricky, especially at Parkwood when this is someone's place of residence, like this is their home, it's where they live. So it's a problem, yeah, and I don't agree with it.
What age do you have to be to make your own decision on this, 18?
Yep, so that's part of, so we're kind of, this has just turned into question and answer, and hopefully this is working for you guys. But that kind of touches on the second part. So the question was, how old do you have to be? So you have to be 18, and that's the original rule back in 2016 that you had to be an adult to consent to this. And that has not changed, although it is something they're considering. Just so you know, in every other aspect of healthcare, there is not an age to consent. So if the healthcare team believes you are capable of making decisions with respect to your healthcare, you can make the decision, which makes sense, right? If you're 16, you're old enough to quit school and join the army, you should be able to make a decision about MAiD. You're old enough to be married, you're old enough to have, you know, children, you should probably be able to make this decision. Can a 6-year-old? Absolutely not. Like I've never met a 6-year-old who could make this. And, you know, around, who knows, it depends on the individual. 13, 14, 15 is where it gets kind of fuzzy. But so for every other procedure in medicine and surgery other than MAiD, there is not an age, but for MAiD it's 18. And is that fair? I mean, if you're 17, I would argue you should be able to make that decision. And that's one of the populations that's being considered with the new legislation. And I think the day will come where it becomes a little bit more open and a mature 15, 16-year-old, 17-year-old would be able to request this. We've had requests, and that's a quick, easy, unfortunate no, because it's illegal. Yes, sir.
There's a lot of controversy going on about the legislation that's supposed to be put through on orders from the Supreme Court with respect to people with mental illness or like with dementia. That until they put that legislation through that these people can request MAiD, is this the workaround that you have on this now, where I can go see you when I'm still cognizant? And then just wait maybe 6 months or maybe a year before I will physically be in that condition to not be able to make my own mind up.
Okay. So that's two questions for sure. So they're both, the dementia question is probably a little bit easier. So the first question was, can people with dementia request MAiD? Not right now. I don't anticipate that changing anytime soon, but dementia is a spectrum, of course. So, you could have mild dementia and a doctor may still believe that you're capable of making these decisions, and then it would be acceptable. If you're so advanced with your dementia that, no physician. And the other point I want to make is different physicians may have different opinions. So if you see one doctor and they say, I don't think they're capable, you may be able to find another doctor who feels that you are, and that's okay. But yes, that is a bit of we've made progress, right? So that at least if you know that your dementia is progressing, there is an option for you so that you still will be eligible. So that's question one. Question two is probably a bigger question. So that's the mental health question. So the ruling came down from the Supreme Court that in spring 2022, a year and a half ago, patients suffering from mental health disorders would be eligible for MAiD. What happened was the system wasn't ready for that. We didn't know how to handle it. So we deferred for a year. So in the spring of 2023, 6 months ago, we were supposed to start doing this. Not ready, deferred to spring of 2024. Just recently, we heard that they will not postpone this again. And myself and our hospital ethicist have been working pretty closely with the Department of Psychiatry at the hospital. And we're not ready. And I doubt very much that we'll be ready in the spring. I'll just give you two different perspectives. My own opinion is this is a very complex problem and it's a very difficult problem. On the one hand, mental health advocates for decades have been saying that, arguing that mental health is a disease, just like heart disease and stroke and cancer. And that's gained a lot of traction. I mean, that's what, that's the going understanding, the way patients with mental health are treated. So by that rationale, well, they're entitled to MAiD just like somebody with cancer. However, the very nature of mental health really calls into question somebody's capacity to consent, to be capable of making the best possible decisions that represent sort of how they truly feel. And so it's difficult to reconcile these two situations. And we've had many requests over the years from people who have mental health disorders. It's very tough. I remember one case where, so they're easy. In the past, they've been easy because we just say it's illegal. Sorry, we can't help you. But I do remember the type of case, and for me, I don't mind sharing that it would have to be a very, very extreme case for me to consider it. And I will tell you that just because a patient meets the criteria doesn't mean that I have to proceed. And I've had cases where I've told patients, there may be another doctor who's willing to do this, who thinks you're capable. I think by the letter of the law, you probably are eligible, but I'm not willing to do this. And I'm allowed to do that. And families get upset with me. But at the end of the day, I need to be able to live with myself. So this patient spoke to me, and he was around my age, and he said to me, my life is great. I've got a wife who cares about me. I've got wonderful kids. I've got a great job. I have a great house. I've got everything I ever dreamed of, and I should be happy, and I'm not. I'm miserable. Every day of my life, as long as I can remember, since I was a kid, I am miserable. All day, every day, I'm miserable. I want to die all day, every day. I've taken every class of medication for depression there is. They don't help. I've had electroconvulsive therapy. It didn't help. I've had cognitive therapy. It didn't help. Like, there is nothing I can do. And I said to this person, I can't help you. I'm very sympathetic, but like, it's illegal. I can be charged with murder and go to prison and lose my license. I can't help you. And he said, and he was an inpatient in psychiatry. And he said, and I'm being fairly vague here to protect his confidentiality, not that, so I'm pretty sure nobody, even if you knew this person, I haven't given you enough information, but he just said, well, I'll get out of here and then I'll do it myself, which is really, really sad. And the reason he was admitted was to protect him from himself, but that was a tough one. And just to take a bunch of steps back, I mean, back before legal, there were some horrible cases. I remember a case of a couple, a married couple, a husband and wife in their 90s, who held hands and jumped off the 16th story balcony in Toronto onto the street because their health was so bad and they just didn't see any other way out. And I had a case here in London where an elderly gentleman got his rifle and shot his wife in the head, you know, his wife of 50 or 60 years, and then shot himself. And I'm pretty sure he didn't just one day after all these years decide that, you know, he was trying to do it his wife, more that, again, it was sort of a mercy thing in between the two of them. And we can do better than that. And those are the types of cases that motivate me to be involved. It's, from my perspective, there's nothing fun about it. It's quite horrible. I don't enjoy doing it. You know, there's a lot of downsides to me personally. I can tell you the pay is terrible. There's not really a way to get paid for this. And I mean, almost no amount of money would be worth it, but the pay is terrible. Like I make far less doing this than if I just continue doing my regular job. The only reason to do it is for these cases like that, you know, where people jump off balconies or you know, are by themselves. Because really, when you commit suicide, you need to be by yourself, because anyone who's with you can be charged later for, you know, assisting, because that's illegal. And there have been some great cases that, you know, I remember fondly from the years where, you know, it does give you a window into people's very private lives. And there's some really great stories, and a lot of families, you know, are very supportive of people. And there's, you know, classically a lot of, like, you know, hugging and then crying, and then someone says something slightly inappropriate and everybody giggles, and then they laugh for a little bit, and then there's some crying some more. And it, in a lot of ways, these cases really bring families together as well, which is really nice to see. And I gotta tell you, it's the weirdest thing in my job. You know, patients survive. I get very little thanks from families. The patients who die, whether it's from withdrawal of life support or MAiD, there's so much gratitude and so many thanks and hugs, and so at least you do feel like you're helping people, even if you're not curing them. Go ahead.
Do you get paid for doing it?
Yeah, so the question was how much? A lot less than my usual job. Maybe I'll just about like that. Yeah.
Don't answer that.
Yeah, it's a little bit more than minimum wage, but not much. Go ahead. We can't, that's illegal. No tips, that was the question. Go ahead.
I want to know, you're doing all of these things for people. What is the medical area doing for you? I mean, you just said that this is not always the easiest thing for you and your family, I presume.
Mm-hmm.
So who supports you?
Yeah, so it's a good question. You know, what supports are available for physicians? It's got to be difficult. So I do a fair bit of research. Half my job is research, and that's one of the questions we're working on in, I believe it's Belgium, where this is legal. They do have a rule that limits the number of cases any physician can do in a year to, it's 3 to 5, something like that, because they feel like any more than that would be too hard on the docs. I know people who do that many a week.
Wow.
And so, yeah, you do wonder. And, you know, PTSD is certainly a real thing. And I think it's starting, it's kind of early days to know what kind of a toll this may be taking on some of the providers. But I mean, for people who've been doing this for 7 years, you know, maybe we will, we'll start to see. And I have a student who's helping me do some research on this. The way I protect myself personally, there's many ways, but the big one is to be extremely strict about who I'm willing to do these cases for. And so all my cases are patients who are dying. And you know, I've not lost a minute's sleep over any one of these cases, because in every single case, it was black and white in my mind, very clear. You know, they were all going to die, and we were giving them control of their death rather than, you know, a horrible death. And on that note, like you know, the palliative care doctors are an interesting bunch, and I work really closely with them and have friends who are palliative care doctors. When this started, this is an estimate, that 80 or 90% of palliative care doctors were very opposed to MAiD. And I think a lot of them, the belief was, well, if we provide excellent palliative care, you don't need MAiD. My own opinion is it's an extension of palliative care, right? If we control your symptoms as best we can, and if and when we can no longer control your symptoms to your satisfaction, there's this option. I also believe that everyone who might be interested in MAiD should be offered this. So it's a rule in medicine in 2023 that we give you options. You have a broken leg, well, you can have a cast, or you can have a splint, or you can, here are your options, here are the pros and cons to each option. What would you like? Well, if you've been told that you have metastatic cancer, in my opinion, your option should be, well, there's this chemotherapy, and here's the pros and cons. There's chemotherapy B, there's chemotherapy and radiation, there's palliative care, and there's MAiD. And if the person says, oh my God, I would never want MAiD, then you say, sorry, I hope I didn't offend you, no problem, we won't bring it up again. But what I find very upsetting is the number of patients still, 2023, who didn't know that MAiD existed, didn't know it was allowed. And we're also still seeing doctors obstructing patients from having MAiD. It's against the college rules, but people still do it. And one of the ways they do it is to tell you, that the patient says to their family doctor, well, it could be any kind of doctor, I'm interested in MAiD, and they say, oh, you don't qualify. And really, they're just obstructing them. Like, they haven't done a fair assessment, and unfortunately, that still does happen. In the back, sir.
Two questions. Reference this, college of doctors prevents doctors from preventing MAiD surgery. How does that reconcile with St. Joe's not allowing you to talk to?
Yeah, so the question was, well, if the CPSO, the College of Physicians and Surgeons, prohibits physicians from obstructing MAiD access, then how do you reconcile that with St. Joe's policy? St. Joe's isn't a doctor, it's a hospital, it's a Catholic hospital, so they are not governed by the CPSO. Go ahead.
The second question is, be interested to know if you've ever had any feedback from any heads of church, various denominations.
Yeah, great question. So the second question was, have we had any feedback from heads of church? No, not directly, but a colleague of mine speaks publicly about how one of his first cases back in 2016 was a Catholic priest. And he was a little bit surprised, and he said, Father, I'm very supportive of this, but I'm a little surprised. And this priest said to him, like, I'll never forget this, he said, I think my God will judge me by the way I've lived, not by the way I choose to die.
Did you ever meet a doctor out in BC that I think she did the animal program in Canada?
Yeah, Ellen Wiebe.
No, Reed?
Wiebe, W-I-E-B-E.
I remember Dr. Reed, she wrote a book on it.
Don't know who that is. Ellen Wiebe says that she did the first case, and she's in Victoria. Yeah, I think so.
Yeah.
We've communicated by email and I think on the phone. So yeah, I know of her and we've communicated.
She got a hard time. She started it out of BC, Victoria Island. Hard time for everybody.
Yep, she certainly did. In the back.
Just to be clear, MAiD is only, you can only use MAiD if you have a terminal illness, is that correct?
So the question was, you can only have MAiD if you have a terminal
So for somebody
illness.
that's got pain, is older, has no quality of life, sees no use in continuing life, MAiD would not be.
Yeah. So great question. So you know that you know your content when you can anticipate every single question from the audience within 2 words. So it's almost as though I planted your question. So that's back to the second part of what I wanted to talk about. So originally, you're right, you had to be dying. Your death needed to be foreseeably imminent to qualify for MAiD. And that was the case the first time I came here a number of years ago. But then people said, well, how is that fair? This person is suffering for 2 months. They're going to die in roughly. My diagnosis is I may suffer for decades and I'm not eligible. That's discrimination. That's not ethical. That's not fair. That's a pretty good argument. Pretty hard to argue with that, right? And so they changed the legislation. So track 1, it's called, is your death is foreseeably imminent. And the rules are a little more liberal. We don't need to have a waiting period. That's the big one. But track 2 means you're suffering terribly. And suffering could be, and there's documentation about what constitutes suffering. So it could be pain, it could be things like shortness of breath, it could be a loss of dignity, it could be a loss of independence. There's a whole bunch of examples of what constitutes suffering. So people who are suffering are now also eligible for MAiD. Great question. Yes.
If I gave you an advance directive, when I was no longer of sound mind, and you had that advance directive, and then you moved away, far away, are those records then sent to my physician? Or if I'm, you know, on the way out type thing?
Yeah.
And can't at that point give an advance directive?
Yeah, so let me
What happens
paraphrase.
with that?
So you sign the forms with one doctor and then they leave. They're gone, they've left the province, for example. Other doctor can use them.
No.
Yeah. I don't make the rules. Pardon me?
Would my family or caregiver be notified that you've moved away?
Yeah, so typically it's fairly new, this process, and usually people don't do it like, you know, if I lose capacity 5 years from now, it's usually they're losing capacity, and usually it's over a period of months. And so we haven't had anyone move away, but we would, I'm sure, reach out and let you know that, yeah, this person is moving away or no longer doing MAiD or something like that. Yes. Yes,
Is
ma'am.
there a time limit, like if, once you've been approved? How long is that good for?
Yeah, good question. Is there a time limit? There isn't legally a time limit. Sometimes we'll just do a reassessment just to touch base to make sure that people are okay, because we need to be comfortable with it as well. And we know from other areas of medicine that just because you provide consent in 2015, maybe things in your life have changed since then. And people should be aware of that for other advanced directives as well. You know, sometimes talk about difficult families challenge that. You know, we'll have a document and they'll say, oh, but that was 10 years ago and a lot has changed since then. You know, they have a granddaughter now that they want to spend time with. And so that makes it very difficult for us when family challenges something. So keeping these things current is a good idea. And that includes like powers of attorney as well, because people can still challenge these documents. You know, if family comes forward and says, well, they used to be friends with that person, but they haven't spoken to them in 20 years. They don't even like them, and, you know, gives examples. It makes our lives very, very challenging, because ultimately we want to respect the patient's wishes. And if you have a family that seems genuine, who's calling into question, you know, old wishes, it's tough to ignore those challenges. Oh my goodness. Go ahead.
So, I personally would not want to go into nursing home. And so at what point is that allowed to apply for me? This very old age, and I can't go to the bathroom myself, but, you know, I'm mentally, like, there's a kind of an aging thing.
Yeah. So, you know, what if I'm just getting older, essentially paraphrasing. So we have a lot of consults for this and a lot recently. And I told you before that you know, the way I protect myself is I'll only do things that I'm comfortable with, that I can live with. And I'm not willing to do those. So I've had lots of patients in their 90s, and, you know, they've got some arthritis and they've got a little bit of, you know, trouble breathing and a little bit of kidney failure, but they're not on dialysis. And I just say to them, I'm sorry, I'm not willing to do this. And I'll tell them, nobody's stopping you from reaching out to a different doctor. Somebody else may be willing. I know all the doctors, there's not very many of us at the hospital, and I'm pretty sure nobody else at the hospital will either, but you're more than welcome to, you know, try to get another opinion in the community. And people get very upset. And the response usually is, like, I'm 93, of course my death is imminent. I mean, people do live to be 100 and something, right? It's not that simple. And I'm not comfortable with it. I won't do it. And I understand. And you know, people say the things that you just did, man. Like, well, what about my dignity? I can't get to the bathroom on time and I won't be able to live. and I'm sympathetic, I am sorry, but like, I'm not willing to start, doing this procedure for people just because they're old and kind of falling apart. And that's my right. Go ahead, sir.
If our primary care physician is not going to go through something like this, can you just say something?
So if your family physician isn't willing to do the procedure or isn't willing to help you find someone?
Yeah, both.
Both? Yes, absolutely. You can go around your family physician, and most family physicians don't do this, are not interested in doing this, aren't willing to do this. And so, sure, you can just call the hospital and speak to our MAiD navigator. The other thing that our MAiD navigator has a lot of contacts in other areas. So I've had people reach out from, name a small town far from London in Ontario, and I'll say, I don't really know, but our MAiD navigator has a lot of contacts of other MAiD navigators around the province. Talk to her and she'll do her best to find someone for you. Very sadly, there are huge gaps in provision of MAiD in Ontario, and it's mostly the smaller towns. And our hypothesis is that, when there's 3 or 4 family doctors in a small town and they live amongst the population, if you have a town of 5 or 10,000 people, it's really important that you get along with people. And if there's a lot of sort of anti-MAiD feeling, a lot of willing to do this. And, that's a huge problem. And just north of London, there's a bunch of areas where there's never been a MAiD case, and we know how many MAiD cases we have for a population of 500,000 every year. So when there's huge geographical areas with hundreds of thousands of people and they've never had a MAiD case, surely there's people in that area that wanted MAiD and unfortunately cannot access it. And that's really unfortunate, I think, but it's just it's a reality. Yes, ma'am, and then over here.
You commented at the beginning that Quebec is slightly different and ahead of Ontario. Is Ontario caught up now with this change, or was it different?
Yeah, so Quebec just did it first. So it was legal in Quebec about a year, maybe a year and a half before it was legal in the rest of the country. That's really it. They were just a bit more progressive than us. Yeah, to my knowledge, that's really the only big difference. I don't think so. Like, a lot of the rules have now become a lot more standard across the country. So I think it's pretty similar in Quebec as far as I know. Just before I forget, if for people that like to read books, a few years ago, my wife gave me a book about this for Christmas. And I kind of said, oh, thanks, that's really nice. I do this every day. It's super depressing. But I remember a few months later, I pulled it out, and I was so inspired by this book. The lady who wrote it is Sandra Martin, and she's I think she is now. She wrote this a few years ago, but she's a reporter for the Globe and Mail, and I love how reporters write. Like, it's just succinct, clear, easy to understand, and she talks about the history of MAiD, and she compares it to all the classic cases, legal cases over the years of people who challenged the court system and lost until they challenged the court system and won, and it was really, really inspiring for me. Talks a lot about how Quebec was a little bit different than the rest of the country. I thought it was a good example of how Quebec really led the country. Sometimes they don't lead the country, but in this instance, I thought they really did. So a great book if anybody's looking for a book about this.
What's the name of it?
A Good Death. Sandra Martin. Yep. I actually reached out to her to help me write a book about this, and she didn't get back to me. Yes, sir.
Could we move on to what's threatening
Yes.
today? And
We absolutely could, except we've pretty much covered it. So the things that I wanted to cover were, recent changes was the whole being able to, if you have declining capacity, being able to have, it's not exactly an advanced directive, but something like that. That was one. Minors accessing this was another we talked about. People who are not dying was the third main group, and mental health. So those were the big ones that I really want to talk about. I think we've covered them all.
Isn't there a group of people who are we're trying to roll back these advances?
So the question was, isn't there a group of people trying to stop this? I think there are, and I don't think they've got much traction, and I personally, I don't anticipate that they're ever going to undo this, is my read on the way things have been going. If anything, it's every year it's opening up more and more. This psychiatry problem, this mental health problem is a big challenge, though, for sure.
Sure thought, doctor, that Quebec is going over and above or beyond the rules. Say do about 3 times as many as Ontario is doing right now.
Yeah, so
Per capita.
so I wasn't aware of that, if that's the case, but I do know the place that does the most per capita is Victoria in Canada. So that's been a concern of legislators. The other thing that we've done in Ontario, we're in the process of doing, so I guess your point, sir, this was the Chief Coroner of Ontario has formed a working group of a bunch of experts to review controversial MAiD cases. And I think the concern is that maybe a lot of different people are maybe pushing this a little bit too far, because that's part of the problem with these track 2 cases and the suffering is, there's some very clear cases where somebody is suffering terribly and almost everyone would agree. And there's other cases where they're not suffering at all and almost everyone agree, but there's a huge gray area in the middle. And I think that's part of why they're going to start reviewing some of these cases, just to make sure that we're the rules are being followed and people are not pushing things too far. Wow, no hands.
Oh, would like,
Please.
how can we help you? Sounds just good, full of bunch of folks.
Sure, it's a great question. So how can you help?
How can we help you?
Pardon, sorry, say again, sir.
How can we help you?
Yeah, I mean, we're doing pretty well at the hospital, and I think the big thing, ultimately, a lot of my life is dedicated to trying to help sick people, ideally heal them, but when we can't heal them, keep them comfortable. And I think sharing some of these messages tonight with your friends, family members, colleagues, it was heartbreaking to me that my youngest son, several years ago, he's a soccer player, and one of his friend's dads had a life-ending brain cancer. They couldn't do anything. I can't remember if they tried to operate on it, but they tried radiation and chemotherapy, and no matter what they did, it just got worse. It just kept getting bigger and bigger. And the last few months of his life, he was everybody's friend. He was a super nice guy. He was always on the side of the soccer field. And towards the end, he was not him. And he was, the way he behaved, he would have been horrified if he thought that his wife and son would remember that, because that wasn't him at all. It was nasty and aggressive, and that wasn't him. And it was a really tough, this was quite a number of years ago. It was tough for me because my wife and I talked about it and thought surely many people would want MAiD in this situation. And this was a little bit before, by the time, he actually died, he was not eligible for MAiD for sure, but really awkward situation for me, to bring this up on the side of the soccer field. And finally, a lot of people will come and just talk to me on the side of the soccer field and, hey, can I ask you something? And it's going to be, some heavy medical question. So his wife came and talked to me, and I just, then that was an opportunity to bring it up. And this would have been, I'm guessing, maybe 2018 or 19. And I said, have you considered medical assistance in dying? Or do you think that's something he would be interested in? She said she had no idea that was even legal. Didn't know it existed. And, I was surprised by that. And I thought that was really, really sad. And also this person had seen several oncologists, cancer specialists, several palliative care doctors, and nobody had mentioned it. And that too was pretty unacceptable in my opinion. Yes.
Can you see in the future getting around this little glitch that you have to, if you have reduced capacity, you sign for MAiD, and then you deteriorate mentally, that you aren't able to initiate it at the last moment when you need to.
Yeah.
about having that one doctor. You said you could do it if you have that one doctor.
Yeah.
Are we working towards getting away from that so that you can actually
yeah.
have that directly?
Remember, it's easy for, so maybe I'll repeat the question. You know, do we expect that there'll be a way to get around it only being one doctor? And what if that doctor leaves or something like that, or isn't available when you want it? Remember that it's easy here as we're sitting here comfortably, you know, in comfortable chairs, sipping our water to criticize, but all these rules are in place to try to protect patients. And I think the reason they do that is so that, you know, when Granny gets a little bit confused, you don't sign her name on the bottom of a form, take it to a doctor and say, she doesn't want this, you need to give her MAiD. I think that's why they did this, right? Because you could completely see that happening. Whereas if I'm the person who's talked to Granny before she was confused, you know, I'll know if you're, you know, you can't fake it if it's me. So I think that's why it's in place. But could I should be able to say, call my colleague and say, hey, I'm out of town, I'm on vacation. Mrs. Jones, I met with Mrs. Jones a month ago. I saw her sign. Do you mind? And that should be legal. So I think that's very reasonable, and I hope we move towards that. I do think, though, that somebody should have met the patient while they were capable and heard it with their own ears to try to protect people. Just my opinion. At the back.
London Free Press is doing a really great job lately of addressing the homelessness situation and the partnerships that are going on throughout the community to address homelessness. And I saw that London Health Sciences is participating in that and housing some of these homeless people. Is this a contingent or a cohort that is looking for medical assistance in dying? I don't really like that terminology. I like life closure better, and I think there's too many letters for an acronym, but this in dying kind of puts barriers up in people's minds.
Mm-hmm.
If it's life closure, a natural part of life closure is a little easier. But I'm worried about this whole relation to say, I have no place to lay my head. I'm living in the streets. It's cold. Nobody cares about me. Is that a group that would end up through the emergency rooms at the hospital and then saying, I have no purpose in life, I'm sick, I'm frail, I have no place to go?
Sure. So the question is there a concern, or have we experienced people whose lives are in a bad place, such, for example, homeless people requesting this? And we haven't seen that almost at all. You know, in 7 years, I maybe have heard of 1 or 2 cases. I'll tell you, it's the opposite. So the other criticism that's been all over the press intermittently for a few years is, you know, this is the healthcare system trying to take advantage of people of low socioeconomic status, people without means to support themselves, people with less education. And it's probably the opposite. There was a study in the States. They don't have MAiD in the States, but they do have in about 5 states physician-assisted suicide. And when they studied it, it was exactly the opposite. It was people with who are financially successful, highly educated, that tend to request this more. My own opinion is, or my experience is, that's the case here too. It's people with more education and more means, people who have had control of their lives for most of their lives, and now their health is starting to fall out of control, and they have the knowledge. They know how to reach out to the MAiD navigator at LHSC. They know how to use the internet to find somebody in the community to maintain that control of their life. And the other thing is the whole concept. I hear that all the time in the ICU. Well, doctor, we hear what you say, that, you know, Granny's going to die, but we're hoping for a miracle. I've never seen a miracle ever. I wish they existed. I wish I believed in them, but I don't. But what we find is that people with less means and less education tend to be the ones hoping for a miracle, and more educated, brighter people tend to know that they don't exist, and they're the ones that reach out. We actually did a study a few years ago, myself and one of the Western medical students, trying to prove this locally, and we used economic status and education, and we didn't prove. What we found was there wasn't a difference. So there was no, you know, people less educated, moderately educated, more educated requested MAiD at the same rates. Same thing for financial status. It didn't really make a difference. And my own opinion is, like, we see a lot of homeless people and stuff like that at the hospital and in the intensive care unit and emerge, and most of those people are survivors. they don't want to die, and there's a lot of mental health, so that's different. Like, but your average person who doesn't have mental, and a lot of people on the street for sure have mental health problems, but those that don't, they're survivors. In my experience, they're not looking to die.
One final quick question. You would be the primary doctor that would say, yes, this individual wants me, and I agree it's right for him. You would only have to find one other doctor. You would say you need two doctors.
Yeah, 2 doctors or a doctor and a nurse practitioner. Yes.
Okay, so it would be yourself and another doctor.
Yep. And sometimes I'm the assessor, so I don't do the procedure, and other times I do both, the assessment and the provision. Today, for example, I did. Those are pretty easy ones for me because I just say, oh, yes, I think so, or no, I don't think so, and I leave and don't have to do the hard part then when it comes time.
Did you refer a patient after she comes to another doctor then?
Yes, we don't, so the question was, can you refer a patient to another doctor? We don't usually need to do that because we don't get the referrals directly. At the hospital, they go through a navigator. And so that person will just assign either 2 doctors or a doctor and a nurse practitioner. I think maybe we'll wind up. So I saw one last question and then maybe we can wind up. Go ahead.
What are the drugs that they use?
Question is, what are the drugs? So different people use different medications. The ones that I use are something called a benzodiazepine, which is also known as an anxiolytic, which is a drug that takes away anxiety. It's a little bit sedating. We give it to people. It also causes amnesia, and I give a pretty big dose. And I always tell people exactly what to expect. When I meet them the first time, right before the procedure, I tell them and their family and their friends exactly what's going to happen. So no surprises, everybody knows. So the first medication if I give you like 4 or 5 glasses of wine pretty quickly, you just kind of relax, probably still conscious, definitely still breathing, still have a good blood pressure. Some people close their eyes a little bit. I could wake you up if I tried hard. The second drug is, and most of us are pretty similar. The second drug is an anesthetic. So we give a very big dose of the anesthetic. So once that's done, the patient has no more awareness. They're completely unconscious, unaware of their environment, and then their heart rate and their blood pressure and their breathing just slow right down until they stop. I tell families that there's often a little bit of snoring, and everybody giggles. Like usually I can anticipate these little giggles. If there's someone who snores, you might see 3 or 4 snores. And then the last medication that we give is it's a drug that paralyzes your muscles. You're already completely sedated, but this just makes sure that there's no little bits of breathing. And so people stop breathing and then their heart stops. Usually takes 1 or 2 minutes, extremely humane all the time. I always tell people that I've never had a patient lose control of their bowels or bladder or seize or anything awful. The worst thing that ever happens is a few snores. All right, well, thanks very much to everyone.
And if you go home and you think of anything, I've got his contact information, so I can fire off any further questions that you may have.
Sure.
So thank you, whether this is for you or for Mary.
Okay.
There you go.
Thank
Thank you
you.
very much for your time, and thank you all for coming.